So we went over a little bit, but we were allowed by the director here to go over. And so I wanted to open this up for discussion. And I think there's a lot of people in the room I've had personal discussions with, and I'm a member of the IDSA and ASAM, and there's a couple of us here who were part of writing the letter to NIH. And I don't know if there's any NIH representatives here, but would anyone like to ask a question, or is it so? As the moderator, go ahead. I don't want to take your.
Follow up from yesterday, we said IDSA will be here today.
Yes.
Hi. So Ben Linus from Boston. So yesterday we talked about the idea of infectious diseases doctors playing some role in addictions medicine, and that for certain types of patients it feels like the natural home to be doing bute prescribing in ID clinic. How would and so we started thinking about the idea of that being part of ID fellowship. And is that, I think it's complicated, but I'd be curious to hear how IDSA would feel about that.
I think it is complicated, because I think, first of all, when you're designing fellowship programs that will be accredited nationally, you've got to look at what is core and what is optional. And I think core, you don't want to be a situation where every ID fellow has to get trained in something that they're not likely to practice in. That said, I think there are opportunities to look at expanded skills and to look at ways of specifically ensuring that those fellows who have particular interest in, for example, treating vulnerable patients with addiction, can get those skills without actually having to do 2 extra years of training. And I think one of the things that we have been increasingly open to is the notion of both looking critically at dual boarding. For example, an example that's currently ongoing is getting boarded in both critical care medicine and infectious diseases, because there are fellows, trainees interested in doing that. And you want to try and shorten that training process so that people can be adequately trained. And then the other approach, which we've been doing around the issue of antimicrobial stewardship. So that's an example of something that is core ID business, and is now part of the core specialty training. But you have a whole generation of people who came out of ID fellowships before antimicrobial stewardship was. So you have to have this upskilling capability, and looking at how you could provide that upskilling capability for people who are interested and want to do it and want to make it part of what they do, without having to take time out of work or do a new fellowship or do something differently. And I think it's a matter of being creative. It's a matter of working with a partner specialty about saying, how do we get the training for infectious disease physicians to be safe, appropriate providers in the interests of patients, but not do it in a way that sort of creates a new bureaucracy. I'm not a big fan of either ABIM or the ACGME, so creating new bureaucracies is not.
Yeah, and speaking of someone who did both board certifications, but I kind of feel like since we are talking about as an epidemic, both of these, that maybe is there a way? I know you don't want to make it a make it a that it has to be done, but what is a way that we can help infectious disease physicians as well as other primary care doctors, family doctors, access training quickly to get their waiver, such that if it is something they're interested in, which we heard quite a few people ask that they can do this. And one of the limitations of getting their waiver is they have to go through an 8-hour training session, and many are very busy. So I don't know if ASAM would be interested in helping out.
So I can speak to ASIM's. I cannot speak to ASIM's position on getting rid of that 8-hour requirement. I know that we do not have a requirement for opiate prescribing. Buprenorphine is safer, just in terms of pharmacology, than full agonist opiates. But ASIM is a leader in terms of training physicians who are looking to get waivered, and offers a number of different opportunities for that training, including adding pre-course sessions at their annual meeting and things like that. The addition is that we talked about workforce development and expansion. So it's not only 8 hours, it's 8 hours for physicians, but for our physician extender colleagues, nurse practitioners, physicians assistants, it's 24 hours. And so, right now it is what it is. And so ASIM will just continue to work to educate the workforce.
Yes, go ahead, Dr. Walitsky.
Hi, Rich Walitsky, Office Assistant Secretary for Health, HHS. So there clearly is a need for more research and for a longer-term view of what needs to be done 5 years from now, 10 years from now. But I was wondering could you highlight maybe one or two things that each of you thinks can be done today, that we know enough to take action, change policy, change procedures to really make a meaningful difference on this intersection between infectious diseases and the opioid crisis? Thanks.
So I think there are, you've heard some very straightforward policy issues around access. Ensuring gaps don't occur, the issues around losing Medicaid in different circumstances. I think that's something that would be immediately helpful. I think in regard to training, we could, I think, rapidly, if the opportunities were in place, we can increase the number of providers. We have technology with regard to telemedicine. We have to be able to actually make it financially reasonable for people to take the time to do it. So we have to be able to have, and that's a matter, for example, of making sure that there are no barriers to reimbursement. And they're administrative. They're not in many cases. So they could be fixed by the administration. They don't need Congress. If we have to rely on Congress, we'll be here for too long. So there are practical issues such as that, and I think yes, we need to be able to do research. And I mentioned, for example, long-acting glycopeptides but one of the barriers to actually even doing that in terms of practical research, creating a database that you could then do without actually having funding for the research, is the fact that nobody will pay for those drugs because they're currently not FDA approved for it. So you have this catch-22 where ID physicians want to use them, believe they could be very useful, but they cannot get any payers, and specifically they cannot get the federal payers to pay for it. So again, administratively looking at the ability to pay for these things, and then you can put practical research as people are actually doing the work in place. So there are some. They might seem low level, but believe me, they'll accelerate interest and they'll accelerate our ability to respond.
I agree with a lot of that, so I'm sort of processing it. I think integration of care between, for example, hepatitis C, HIV specialists and addiction specialists, integration where patients are, so either in a methadone clinic or you go out to where they are. I also think that using every single interaction with the medical profession as an opportunity to get people engaged in treatment. So there's some of that is being done in emergency departments, also in hospitals, and I think that should just be standard. And one thing is starting buprenorphine treatment in those settings and then linking the patient to treatment in an active way, not in a, well, here's a referral, because that's often where things fall apart. So linking and integrating, I think, are extremely important.
So I would concur with what my colleague said. I think the other thing, again, is just removing those barriers to what we know as effective evidence-based treatment. So, working with payers to get rid of those prior authorizations for addictions treatment. We also know that while Medicaid pays for addiction treatment, Medicare does not. And so I think that's one of the things that when we talk about something that we could look at today, look at expanding Medicare coverage to addiction treatment, particularly as we've seen in some of the presentations, we've got an aging population who's not able to access treatment.
Great, and I agree with all of my colleagues. And the other one I would say is, which Dr. Powderly mentioned and many of us have talked about, is we have a great, and Dr. Del Rio has brought up, we as all of us who have taken care of the patients with HIV know about this model of care, and we've had the Ryan White funding for some time that helped was integral in reaching people. And Dr. Powderly had it on his slide, is why can't we use that as expanding opiate medication treatment as well as behavioral services. So if we think of drug treatment as HIV prevention, hepatitis C prevention, overdose prevention, and then the other would be models of care to help reach these rural communities that don't have the healthcare providers. And, there's some great presentations at CROI, looking at the resource-limited countries who are doing amazing work, doing home-based HIV testing, and we can do the same with opiate use disorder identification and expansion of opiate treatment using community healthcare workers, especially in areas like West Virginia. So maybe thinking outside the box of learning from what we've done in other settings and bring them to the United States, when many of these states aren't, it doesn't look like anytime soon are going to be expanding Medicaid, especially with the ACA. So I'm going to stop and let Dr. Cortez take the next question.
Thanks, and Dr. Springer, I appreciate that statement. I do think that the country is ripe for Ryan White for opioid use disorder. And so many of the lessons learned that we've learned in the HIV epidemic are directly translatable. I'd be excited to see that. I wanted to pick up on one of Dr. Powderly's points and talk about the Rural Opioids Initiative. If people have not heard about this yet, it was just recently funded as a collaboration between the CDC, NIH, and the Appalachia Regional Authority that funds increased study of hepatitis C surveillance and the infectious consequences of opioid use disorder in rural America in 8 states. So much more to follow on that. The second thing that I wanted to just raise as a point, not knowing if the NIH is in the room or not, but the research priority from the Office of AIDS Research, focusing exclusively in their high-tier priority funding on viral suppression and transmission as really the only fundable outcomes for HIV research, I think is missing an opportunity to address the opioid use disorder epidemic. It doesn't help my patients to have virologic suppression and die of an opioid overdose. And our research outcomes should incorporate those as high priority targets.
Thank you. And there's a lot more to discuss, and we'll have plenty of time to discuss it. And I thank you, because that is a, a comment that we have discussed as well. So thank you for bringing that up. So we are going to have to end right now. There's another panel, but feel free to talk to each other and talk to all of these people. Thank you.